After after we complete today's event, we'll go over some stuff from yesterday, clarify any questions. We cover module 2 yesterday. As I mentioned, it's also the most important module because there will be 44 questions from that module, right? That's what in the blueprint, that's what it says, 44 questions. So we'll go over again, clarify anything that you may have thought about after we finish yesterday's event, and prepare ourselves for next week as we'll go through module 3. If you don't have the schedule of the classes, please send me an email. I know I received a lot of emails yesterday and I just couldn't get through almost any as we prepare for today's event and other things that are coming up. But I will respond to your emails today after this class. Okay? All right. Good luck, everyone. Let's the game begin. Okay, 6 seconds, 5 seconds. Okay, well done. Well done. So the difference between a safety plan is what you always want. A safety contract, it's always the wrong answer. Always. If you ever encounter a question that's a safety contract, that is an outdated term, not endorsed by ANA, has been many published articles that says safety contract is not good. Safety planning is a step-wide process to decrease crisis, and it is endorsed by ANA, right, as an effective way to decrease suicidality. Now, the question here is someone with suicidal thoughts and a possible plan, right? Whether we have a safety plan is appropriate at that time or whether an admission is appropriate. I think either one would be a correct answer, right? So the question would need to give you a little bit more detail. But the question also said that he's been taking medication and progressing well, right? So a safety plan would probably take a little bit more of a precedence here, more of a importance. But if if that was not one of the choice, admission would not be a unreasonable answer, right? Because we're getting too close to danger. Okay, but any answer that has safety planning, please consider there as a very strong answer. Okay, and I know that's for you, Rebecca. I know. Sorry. All right. So collaborating, especially if the answer says collaborate, which I couldn't put in an answer there because it was too big of a word, right? Collaborate with the patient to develop a safety plan is a standard practice for PMHNP. Anytime you collaborate, you develop teamwork. Okay, so that alone it's strong. And when you add the safety plans into it, makes a very strong answer. Okay. And obviously, you want to assess the levels of risks, identify coping mechanisms, creating a plan that you feel comfortable After you create the plan, that's when you make the decision whether it should be admitted or not, right? If the patient is unable to create the plan, then there would be a sure admission. Um, let's go over safety planning. Who has done a safety planning before?
I have done a safety plan before.
Are you able to kind of walk me through it, or no?
So I can a little bit. So I
Sure.
do work as a case manager,
Okay,
and
great.
usually when patients come in first, like our initial meeting, we do like a safety plan. That's like a standard practice for everybody. Um,
Right.
we kind of start by asking them like, maybe what are you looking forward to? Um, we also like ask them if they have any guns at home, if the guns are locked. We also
Yeah,
ask
so
them.
I have the safety planning here for you. So what's the first thing you do? Can you walk me through it?
So basically we just this questionnaire is what we do basically. Okay, yeah, he's in front of me. So we ask them like, are there any warning signs that a crisis may be developing? So we don't really word it like this. So for my patients, I just tell them like, are there anything that would make you be aware if you are there any things that anybody around you would notice if you are feeling extremely sad or hopeless or anything like that? And they will say, oh yeah, if I'm grumpy, if I'm sleeping too much, I'm not talking to nobody, I'm isolating. So we list all
Right.
those things down, and then I now go forward and ask them, is there anything that helps you to get out of that situation? And they will tell
Perfect.
you, yeah, sometimes I take shower, I call my boyfriend, I go for a walk. So those are the things we put on the number 2. Then the number 3, then we ask them like, are there people that you feel comfortable that you can talk to without reaching out to a provider or to any medical personnel? And they put that number there. And then for that number 4, they ask like, who can you ask for help? So usually most of my patients come from the clinic. We get referrals from the clinic. So sometimes the clinic might have like a 24-hour line. So that also might be part of that. And then we also do the 988 number. That's for the crisis suicidal helpline. And then eventually we do like the 911 if anything does not happen. So what else? Write out a plan to make. I don't have this on my template. The number 6, it's not really worded like that. Write out a plan to make your environment safer. This one, are there things that they can do that that could actually make them safe? But we also have kind of assess for the home environment as well, like just the normal case manager stuff.
Perfect. Oh, excellent. So yeah, so basically here, as she mentioned, number 1, how do you know a crisis is coming? And then write those 3 things down. How do you know, or like, what can you do to decrease the thoughts of suicidality? Playing video games, going for a walk, and then who are the people who you can call for distraction if you need help? So when I'm doing this, if I feel that the answers are not valid, or if I feel that the patient doesn't have one, then an admission would be seriously considered, right? And I always tell my patient this: if it gets to 4, right, and you can't cope, and you have an urge, and the thoughts of suicidality is still there, please stop everything and call me. If during Monday to Friday, right, I'm in the clinic, 07 to 1700, I'm in the clinic, come to the clinic anytime, or go to the ER where we work, emergency room, right, or call a crisis hotline. Think of it as a way, it's a fire planning, right, a fire drill before the big fire. So if they have this list and they have their phone numbers ready and they know who to call, and they have pre-planned what to do during a crisis, they can pull this sheet of paper and use it. So we all have noticed that when we are anxious, we just can't think clearly, right? It's even things that we know, like our phone numbers, we may forget, or the password to my door, I might forget, because it's not that I don't know, it's just because I'm too anxious, right? So having the safety planning has been shown to, I have done a few papers on this, and has shown to decrease suicidality up to 78% in the ER when it's done at the ER, and the provider does the safety planning, and there is a follow-up. I did this on a base in Fort Bragg for over 1 year, and has really been successful. But it takes the providers to believe, it takes teamwork, right? A lot of teamwork. But I just want to share that. And for you, I guess what's the most important right now, it is passing the board. So safety planning, it's always a good answer. I'm not saying it is always that answer, just because we, consider an admission at this place, at this point, it could be a possible answer, but it is a strong answer. Never safety contract. Okay. All right. Next question.
Can someone share the Cahoots pin, please?
Yes, man. It is 583-1454. You have to pick a nickname, anything you want to be called for tonight. Okay. Or put your name.
Can you please repeat again, Dr. Lopez?
Yes, I sure can. 583-1454.
Thank you.
Absolutely. Guys, so when we think about recovery model, I want you to keep in mind a few things. It is never straightforward. It's always learning and falling, just like life, right? We don't sit down and say, well, we do, because I do this all the time. I'm going to sit down and study every day, 12 hours a day, and this is how every day is going to be. Well, not really. Some days I might not even pick up the book, right? But the intention was to study every day, 12 hours a day, right? Let's say that this way. But that's much of a recovery model. They come in and they understanding the importance of the context, that we want to help them and they want to be helped, but when they fall back, it's something of much expected, right? The recovery model is refers to as kind of a non-linear approach to recovery, expected that the failures will occur, right? All right, I'm back again. It's just Pam, Dreaming CS, and Jennifer Lopez. The real Jennifer Lopez, that? Just kidding. So, as expect to let setbacks, learn from it, and adjust your recovery plan accordingly. So, it's also about working with the patient with what they have rather than working with their conditions. For example, instead of saying you have a schizophrenia, I don't see you as having schizophrenia in a sense, but more of what can you do with that, even though that's a bad example for the recovery model. What I'm trying to say is that we work with what the person has, independent of what their diagnosis is, right? So it's basically a streamline, enhance efficiency of those in the treatment. Okay.
And our Jennifer Lopez is the pink duck Jennifer Lopez.
There you go. Thank you. My cousin, Jennifer Lopez, right? Just kidding. All right. So again, it's short-handed answers, right? I had to say declining because it didn't allow me much to put in there. Stressing the importance of professional boundaries, it's what's most important. I know that I think it was answer maybe C there, compromising and attending a support group together as a friendship, right? Would not be unreasonable and it would not be unethical. But imagine that, think about fairness, right? If you are treating this person this way, you sure want to treat everyone else the same way. When the patient requests for you to attend a group therapy and you do so, and another one asks you and you can't, that's not fairness, right? So you put yourself in this bind. Ultimately, you want to respect the boundaries. And believe me, it is all fine and dandy now, right? But we too are humans and we have feelings, and we are nowhere near perfect, far away from it. And those boundaries can get a little bit unclear at times, right? Depending of our emotions and how we interact with the client, right? So we need to always have this at the forefront of what we do because this is our profession. And whether you believe it or not, we hold a lot of power. We do hold a lot of power. And with the power, it comes a lot of responsibility, right? And if you really think the knowledge that you have of the mind and then so many interactions that you have with humans to humans, you become an expert. And you could use this expertise to do well or not, right? You can take advantage of others because you become such of a master of communication and dealing with those that are at the moment feeling distressed, right? So keeping as you become a professional and you understand the power that you hold, make sure that you always keep the lines very clear, very firm, and you don't deviate for that. Whether it's charting, whether it's the way you act with other professionals in your office or in your hospital, and especially the patients, right? Especially the patients, because it's very easy to get attached to someone that has been going through a trauma, especially if you have gone through the similar trauma, right? So it kind of creates a bond, a connection between both of you guys. So keeping this at the forefront will save you lots of a headache. Every once in a while, I am in a board of committees that have to make tough decisions about professions that have crossed those boundaries. Okay, so keep yourself safe, keep your patients safe. Okay, all right, next question. Okay. Why would A be a stronger answer than D? Anybody can give me
It
some
also,
synapse. Empathy, right? That's what you said?
You
Yeah,
want
Can
to
you go to the
sympathize with them.
option?
Yeah. Do you want to connect with anyone? Show them some empathy, not sympathy, empathy, right? Sympathy is different than empathy. And you guys seen me saying this many times, right? What we bring to the table is two hands, right? The science, you have to be very strong at it, and the hope. And we marry those two together, the science and the hope. So by saying, I'm sorry this happened to you, it must be very difficult. You're not saying that, oh, I know how you feel. Do you really know how you feel? Or how does the person feel? Have you been there? Have you done that? Right? I think we talked a little bit about this yesterday. But simply saying, I'm sorry this happened to you, it must be really difficult. You're not flattering them for no reason. You simply acknowledge their pain and understanding that must be difficult, right? Tell me about the details of your traumatic event. Well, somebody's crying, distress, not necessarily the best approach. Okay. One of my personal goals is to develop a class of communications and how you are able to collect almost any information from your patients by asking the right questions or by allowing time or simply by allowing them to talk, right? I find it very successful. There is a book that I read and I use those techniques all day long. One day I'll get to it. It really is my passion. So therapeutic communication is strong. If you use it appropriately, you can get a lot out of this, right? So I'm sorry this happens to you. It must be really difficult. This response demonstrates empathy, validation, and support. Acknowledge the patient's emotions and convey understanding, which can help the patient feel heard and validated. Who doesn't want to feel heard and validated, right? I mean, at times you have to almost say, okay, the treatment is over. I have seen you 10 times, your medication is stable, but the patient keeps coming back, right? It's like, okay, we got to keep on going. But that's because you have developed a strong therapeutic alliance with the patient. And that is what your goal is, right? Develop trust. Now, since we're talking about trust, remember when dealing with teenagers, right? You want to develop trust. And how you develop trust with teenagers or young children, I guess, how do you do so? Especially for the board.
engage in
You
something
listen.
like, or ask them about something that it's interesting to them.
Okay, that's a good way.
Be
I
authentic.
maintain,
But for the board, we're
I
looking for something
maintaining confidentiality.
confidentiality, right? Now you get in a bind, a dilemma, right? Where you want to serve the teenager, but you also want to serve the parents. And this is very difficult for you because you want to make everyone happy. You want to be professional and you can see from being a parent, most of us, or if you were to be a parent, right? You want to know. But the moment that you tell the parent and is against the teenager's will or permission to do so, that person will never come back. Or if they do come back, they're unlikely to talk to you, right? So you can see the distress that you are put into. So how do we do it for the board, right? Think about the patient's safety. If it's something minor, like a 15 years old, I wouldn't say this minor, but in consideration, a 15 years old dating someone, a 15 years old girl dating a 17 years old boy, right? Consider normal by some, abnormal by others, but it's not extreme, right? But now, if it's the 15 years old girl dating a 20 years old guy, you have to say something about it. You see the difference? Or no? Does it make sense?
Yes.
Yes.
Okay.
Yes.
Okay. I know some of you guys might say, well, still, you know, it's 5 years difference, but by the law, right, that would be wrong. And by many means would be wrong. And some people might think it's right, and, you know, but you have to say something. If it's something like teenager says, I'm smoking weed every once in a while, now it's illegal in some states, and you may feel strongly one way or the other. But if you break that trust, you never get the person back. So you have to weigh the risk and benefit. Okay. All right. Perfect. Perfect. Well done. Okay. All right. Is Rebecca still there? I can't see the screen.
Yes, I'm still here.
All right. So walk me through SIWA, all things that you remember from yesterday. Would you please?
Yes. SIWA is a scale for alcohol withdrawal symptoms. It helps you gauge the severity of the symptoms, gauge the clinical withdrawal alcohol recovery system. Yeah, gauge the severity of the symptoms. I can't think of the second word. Severity of the symptoms. And anyway, bottom line, it helps you set guidelines for your providing of services.
Okay, so what medications you're going to use and how are you going to use them?
You're going to go by the scale, and at 5 you can start PRNs, and at 8 you will use the scheduled drugs.
No.
Okay, wait a second. Can you restate what you said slowly and think about if what you said is correct?
At 8 you start PRNs, and at 15 you start scheduled. Okay. Yeah.
Okay. What are the two meds of choice that we talked about yesterday?
Lorazepam, because it works mostly outside the liver, and you're probably dealing with some kind of liver dysfunction, and clonidine.
Valium.
Diazepam.
Diazepam. So the D and the L, diazepam, and lorazepam for liver injuries like hepatitis or increased ALT, AST. What are the 3 drugs that we can use for alcohol maintenance?
Dan, acamprosate, and naltrexone.
Okay. All right. Thank you. I appreciate that very much. So let's talk about anti-abuse because we have a question coming up on that. Can anyone would be kind to me and walk me through COWS and medications and anything that you remember from yesterday?
COWS is the opiate withdrawal scale.
Okay. And
Alright.
what are the scales that we start to give medications? What number?
At 7, we give clonidine. And at 13, we give buprenorphine or Suboxone.
Okay. Anybody agree or disagree?
Disagree.
5 to 12. We done.
Disagree.
Mhm.
Okay. So really, okay, go ahead. Anybody has a second thought there?
I thought the patient had to be in moderate withdrawal, moderate to severe withdrawal before you could start Suboxone or buprenorphine. Otherwise,
Sure.
it's going to precipitate withdrawal.
Okay, but what number would that be?
Isn't it like 13?
That's 5
13.
to 24.
13, right? So,
Yeah, 13.
so 5 to 13, I mean, this is book answers, right? So somebody said 12 is not incorrect, but usually if you want to be like super clear cut, 13, right? So if we look at CIWA, we look at 8 start CIWA for alcohol. Don't get those mixed up. CIWA 8, PRN only. PRN what? Lorazepam, diazepam. Lorazepam for those with livers. Patient arrived at 15. Now you give the PRN plus schedule med. Done. COWS for opioids has an O in it for opioids, right? Then 5, you give clonidine. Arrived to 13, Suboxone or buprenorphine. Can you give methadone? Yes. However, less likely to be the answer just because of the more complications, cardiac complications, so forth. Okay. Now, as we mentioned yesterday, the alcohol lowers the seizure threshold, and alcohol withdrawal, right, lowers the seizure threshold, and it can be deadly, right? It can cause seizures and cause injuries, severe injuries. Opioid withdrawal is nasty, but usually doesn't kill, right? Any other comments here before I move on?
I have a question about the
Sure.
pregnant. If the patient is pregnant, would you go with buprenorphine or would you go with methadone? Because methadone used to be the gold standard, but is it still the gold standard for testing purposes?
Yeah, I think you would never get a question like that on the test, just because it doesn't have a really clear-cut head-to-head research, right? A lot of people would go with methadone, right? But I don't remember seeing clear-cut systemic review comparison between both of them. So, and would be likely to be a lot of patient dependent. So it's very, very unlikely that you would get a question like that, especially because it's a complex question. Okay. Methadone may have a better outcome, but I would have to seriously look in the research to be able to fully answer that. My gut says methadone, but that would never be a question. That's too in depth. Like that's the highest, like from the substance abuse, that would be one of the highest, most difficult choices. If you answering a question, you can, one of the two. But now think about someone's life, right, at risk, and the person is already vulnerable. You making that choice, it can be very difficult, right? It can put your head for a spin. But I would have to probably do some research on that. But methadone would be my initial concern, but that question would never be on the board because it's way more in depth than what the test is really aiming for.
Awesome.
Okay. Yes.
Dr. Lopez, quick question.
Sure.
I was here yesterday, so I don't know if you addressed this question or not. But one of your student that passed the boards mentioned something about she had a scenario of a patient taking a bottle of citrulline and a bottle of whiskey. Of course, we don't have detail of the question, but I'm assuming it's probably asking which one is safe or what. I'm not sure what the question is. Do you have an idea?
I have no idea, but you say a bottle of whiskey or a bottle of sertraline?
She said a scenario of a patient taking a bottle of sertraline and a bottle of whiskey. Basically, that's what she said.
I have no idea. But I can tell you a few things about that, right? Certainly.
I mean, that's safe for pregnancy, right? To give.
Yeah. Yeah. So, okay, great point.
And then
usually, I wouldn't say safe. I would say less harmful than many other choices. It would be my choice. But do you think that when I'm prescribing somebody on a first trimester, do you think that I don't consult with OB? I do. I do. I'm very confident, very super confident, but I still send them a message like, hey, I'm starting sertraline. I just want to make sure that I have not missed anything since this person in the first trimester. Please advise, right? There is no harm on that. There is no ego. There is an ego. I mean, your ego will be crushed the day that you make a deadly mistake or you harm somebody, right? So there is no such thing as ego. You have teams to collaborate, and you're not the smartest. I'm not the smartest person in the room, right? It is what it is. So that's why we have doctors and other professionals that we can collaborate. So I always cover my 6, right? So if I'm even certainly in pregnancy, I send a message to the OB on the system, say, hey, I'm thinking about prescribing, certainly this person is 2 months pregnant, has been, I got all checks. Do you see any problem? Or are you seeing this patient, or are you collaborating, or you have second thoughts, right?
Yeah, and also I'm also thinking maybe it was saying SSRI and alcohol. If you take a lot of SSRI, you're probably not going to die, but you take a lot of alcohol, you might die. I'm thinking maybe it could be that question. I don't know.
Yeah, I don't know what is the questions on the board, but I can tell you a few things, right? Few things first. Why do we prescribe SSRIs versus the TCA? It's not because TCA is less effective, which in fact would be wrong. TCAs are more effective. However, they come with a lot more side effects. And one of them could be cardiac compromise. If you get a bottle of Lexapro versus a bottle of a TCA, the Lexapro will give you a tremendous diarrhea and cramps and headache, and with the TCA may disrupt cardiac rhythm, right? So another thing about Lexapro, for example, it has the least drug-to-drug interaction of almost all meds. So that would be a huge plus for those patients who are taking cancer medications or having multiple medications, right? So yeah, so I think the question may be something, I have no idea, right? I can't answer what is on the test because I don't have the test and I have no idea. But what I'm saying is that SSRIs are safer than most other options out there. Okay, so now having a bottle of whiskey or a bottle of sertraline or Lexapro, I have no idea what that could be about.
They weren't trying to get us to compare the lethality, which would be the alcohol or the sertraline, were they?
I think no one really could compare the lethality on that, right? Like, in order to compare, you need to do research, right? It has to be research, and who's gonna do a research comparing option A? Here's your bottle of whiskey. Option B, here's your bottle of Lexapro or sertraline. I mean, that's impossible and illegal in many boundaries. So I don't necessarily think it's about how that
the question doesn't compute.
Yeah. So guys, I urge you guys, because a lot of things is said out there and it just doesn't really make sense. It's because the person doesn't quite remember. What do we remember on the tests? All tests, or our weakness. If we're weak on math, we're going to come back and say, gee, there was a lot of questions on math, because that is what stuck with us during that time, because it's something that we had trouble with. The things that you can just, oh yeah, got this, boom, 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 you're rarely going to remember, right? So comparing a bottle of whiskey, which, let's be honest, everybody out there, or most people in the population, they may do a bottle of whiskey every now and then, but not a lot of people take a bottle of a medication very often, right? So it will be impossible to really pinpoint what the question is. I can tell you that both of them would be digested by, breakdown by the liver, right? So both of them would be extremely harmful. Right? But anyways, let's keep on moving. Thanks for the question, though. Unfortunately, I can't really help what's on the test. I can just give you principles of what might be, right?
Thank you.
Absolutely. But keep your questions flowing, because it's not important what is on the test, but it's important that we learn what it's around the topic, right? So here we talked about SSRIs being the safest. We talked about sertraline for pregnancy. We talked about compared to others and the reasons why, and even talked about how Lexapro interact with other drugs and why it would be one of the safest for people taking cancer drugs, right? So we can always talk about a topic without talking about what is in a test, right? All right, 5 seconds. Okay. So if you picked naltrexone or clonidine, right? Unless if it was a mistake, sometimes we try to be fast and we make those mistakes. You really need to kind of review the content of module 2 that we went over yesterday, right? So naltrexone is an excellent drug because has shown to decrease the number of abstinence and also the quantity of alcohol intake if they decide to drink. So that is the plus for naltrexone. However, it is not to be used for alcohol withdrawal, right? Alcohol withdrawal, especially for the test, we're looking at the lorazepam and diazepam. Librium, probably the #1 used in practice, right? Not so much on tests as I've seen it, so books out there, right? And anti-abuse is a aversion therapy medication of a choice, rarely used because it's nasty on the patient. Can be used. I have used a handful times, prefer not to, and it's very hard on the liver as well. Okay. All right. What is your question, Yvette, please? You have to unmute yourself. Yvette, are you still there?
No, what I'm saying is, I just want to tell you that I just passed my board exam today. I just passed. Yeah.
Congratulations.
Thank you.
Congratulations.
Oh my God. God.
Yeah, I mean, like,
Congratulations.
yeah, my congratulations. I will dedicate it to Dr. Lopez because, I mean, I wrote to him. I was going through a lot. I was even thinking of like postponing the exams. But yesterday I asked a question about,
Again, right? Because you did before,
yeah.
right? So I'm so happy.
What did you say?
I think you postponed it one time before, right?
No, I didn't postpone it. I wanted to postpone it, but I didn't postpone it. I just said, well, I'm going to write. Yes.
All right. Well,
Yeah.
I'm so happy. And this is if you don't want to, that was your first time testing or no?
Yes, this is my first time testing. Yeah, but remember I told you I had a lot of relationship issue with my marriage and everything. I told you, and you said, yeah. So yeah. So there was a question yesterday I was trying to clarify with you about sewer.
Sure.
You remember I asked you a question yesterday about sewer, and you said you don't remember, you don't know, because I was asking if they will give us numbers, in the test. Yes, they will give numbers. Yeah. They will give numbers, and I mean, test was very difficult. They will give numbers, and but you have to just add the numbers, and they'll give you options there that you need to pick. I remember a lot of questions. My head is just kind of just heavy now. I'll try to write some of the questions, type them out, the questions that I remember, and just post it in the group.
Don't save it yourself. You can't really post on none of this. But just don't post anything, because you really can't post it. But a few things that I wanted to kind of get back to you on it. So you attended yesterday's class, and then today you took the test. Is that right?
Yes, I did.
Oh my God! So it was good timing.
Yes. Yeah. And yesterday class really helped. It really helped a lot.
Good. Yeah, because I think it was the most heavy, even though it's actually the shoulders of the. Maybe the shortest.
Yes.
It's only 12 lecture, right?
Yeah.
So it's the shortest, but it's the heaviest. I'm always thinking, should I add more to it? But I think we have a very good balance between what you need to know.
No, yesterday's class was very, very helpful. I wouldn't lie to you. It was, I mean, I had a lot of questions from there. It was very, very helpful. I'm glad that I attended the class, I mean, today I came up before I left, I was confident, but when I saw some of the questions, I'm like, oh my goodness, I don't think I'm going to pass, but I was just like, okay, just trying to do my best. The questions were tough, but
they are, right? So I think this way, right? I mean, everyone is different, but the goal is that as you walk in there, you just like feeling like Superman, like this is nothing. I got this. If you put the time, to build your confidence. And when you do that, when you put the time, you've done everything you can do. So at this time, it doesn't really matter the results per se, because if you have done your best, you've done your best, right?
Yes.
Problem is you haven't done your best, and then we feel guilt because you have not done your best.
Yes.
And then you start saying, I'm like, oh my God, I'm gonna fail. Oh, it can be very, very difficult. But it's not to say because it's my course, but I think we really are onto something that's very positive, and that a lot of people, we have over almost 800 people by now. Last year, 754 people passed. So quite a bit of students. This year has been very, very strong, super strong this year. I mean, cannot even, over 99% of the people are passing. But that's because I do ask a lot, right? I do ask a lot.
You are the rock. Oh my goodness. I mean, I'm just telling everybody, please just stick in there, stick in his courses. And I have like a couple of people that are in school. I'm just gonna refer them because it's
thank you.
Your classes rock. I wouldn't lie. Sometimes I was in the hall, I was just recalling like some of the things that you said. That is how I answered the question. But before leaving, even though I was like, it reached a point I started counting the questions that I got right. Then before leaving, I'm like, well, I don't know. you know, but there's some questions were really vague. Some questions were vague, but
Yeah.
every question, especially your crash course review, it was like you are giving the exams to the people, to us, you know, the crash course review that you did. It was like you were giving me the answers, you know, it was so, everything was there, you know,
Yeah.
everything was there.
You know, it's not oftentimes I get this more often than any other comment. People say that they can hear my voice on the test, right?
Yes,
And that's
I
when I
did.
know, like,
Oh,
that
no.
we got, you know,
No.
yeah, like I get this
Yes.
all the time. It gives me chills. I mean, almost on a weekly basis, like I can hear your voice when I was taking the test. I was like, whoa, hopefully that's a good
Yes,
thing.
it's
I don't know if
true.
it's
It's
a
true.
bad
I was
thing or
just
not.
listening. I'm just hearing your voice, like what you were saying. I'm like, okay, this is the answer. This is the answer. This is the answer, you know. And I
Yeah.
finished like about 36 minutes before. Then I'm
Wow.
like, okay, but I flagged some questions. I'm like, okay, I'm going back to those questions. And
Mhm.
some of them were just vague. I mean, I didn't know, I didn't have a clue of what they were talking about. I've never seen them. I just picked anything, just did elimination and picked anything. But
Big user
you know, but
test
I was
taking
so
strategy.
confident with more, I mean, like majority of the questions I answered, because it was like the crash course review and everything that you keep on reiterating, you know, everything you kept saying. It was just like I really finished really early, and you know, I'm like, okay, should I
Yeah.
submit or should
So
I go? Yeah.
yeah, so one thing that I want to tell everyone, this is so important, right? So important. You will encounter questions that you have no idea, right? So what you do, your process of elimination,
Yes.
and know that if you have no idea, it is likely that others have no idea too. Okay? I can't say this with 100% confidence, but if you encounter questions you like never heard of, it is
Yeah.
likely to be a dummy question. And those dummy questions are recycling through it. And if the majority of the people get it wrong, that means to the test takers, I make horrible questions at times. I just
Yeah.
do sometimes, right?
Yeah.
So how do I
Yeah.
know it's a horrible question? If nobody's getting what I'm trying to say, then it's not a good question. And this is what happens too. Obviously, they have a tighter professional organization that look at the questions more carefully. But if you're having questions where 50% of the people are not getting it, then they are to be thrown out. This is
Yeah.
what we do in school too, right? If we do questions and then like after the two tests, the students are not getting, we got to look at ourselves and see why are the students not getting? Are we not giving a good job,
Yeah.
or they're not studying, right? So don't
Yeah.
despair. That's the message. Don't despair. Do your process of elimination. Do what you know. Ask yourself, what is the core of the question? What is the question asking me? And see if the answer is answering the question. Because oftentimes, I went through with someone yesterday's test, right? After the meeting, somebody said, well, I'm testing soon. I'm feeling nervous. I identified a bunch of her mistakes that she's picking an answer that she has no idea what it says due to anxiety, right? Because she is, oh, I don't know what's the answer, so I'm going to pick one that's even more obscure
Yeah.
in order to, because if I don't know, it must be this one, right? Because I have no idea what they're talking about.
Yeah,
And
and I
that is,
also want to compliment you. I mean, compliment the students to take the diagnostic test, the
yeah,
7th and the 8th. There were a lot of questions. They weren't worded the same, but they were like, I mean, it was like 50% of your questions for those diagnostic tests were on mine. You know, I don't know for other people, you know, because when you said people take tests and I took my diagnostic test on Monday and I got 77. I'm like, oh my goodness. But there were places that I know that, okay, I wanted to choose this answer, but I'm like, should I postpone the test? Should I not? But most of your questions, they were worded. I mean, you will see a very few things there that were different, but you gave like almost 50% for my own test, you know, from the diagnostic test
there we
8.
go. You
Yes.
know,
So I
one
just
that
want
we
to
can
thank
say
you.
that if you score an 80% on my test and you have not taken the test more than once, I have no concerns that you will pass. I have zero concerns. Like, you know, when I say 80, sure, I'm accounting for. Does it have to be 80? No, of course it doesn't. We had people that score 65 3 weeks ago, and she passed. We had to do a one-to-one 5 o'clock, 4 o'clock in the morning with her. I mean, I'm not putting her down. I'm just saying that was like rescue mission, but what I'm saying is that if you score like an 80, you have more than enough room to feel anxious and still pass, right?
Yeah.
Like an 80 is a very strong score. But anyways, I want to, hey, Yvette, I want to thank you for showing up today. I know a lot of people do. I'm very grateful and thankful for, for your encouragement and knowing, and like when I get reviews, that's where I improve, right? I find out, okay, what's working, what's not, what I need to change. So thank you for coming in today and give us heads up.
Thank you. I'll continue with the pharmacology course and everything, and
Yes.
I'll be joining your classes from time to time just to review. Thank you very, very much.
Yep. Anytime, you're welcome to come back any day, any year from now. We don't put restrictions on people's learning at all. So
Okay.
thank you again.
Thank
All right.
you, Dr. Lopez. Thank you. Good luck, everybody.
Congratulations.
Thank you.
We'll be contacting you too for help.
Thank you. Okay.
Congratulations.
Thank you.
Well done. All right, guys, we're still in the fight. So let's go get this thing, okay? Next question. Ready? Go. Oh my God, did I, oh no, I didn't. Okay, I thought I turned it off. Sorry. Panic mode.
Oh my goodness.
Oh man. Okay. All right. I had to step out. Can somebody give me the insight of this question here? I had to get some water.
So
yeah, please.
The ones that decrease cravings are going to be your camprosate and your naltrexone. Dysphorium is going to be your aversion.
Okay.
Methadone and buprenorphine are going to be used for opiates.
Perfect. Well done.
Hello. Hello.
All right, so just want to highlight the 2 points here. Acamprosate and naltrexone. Research has been, never say that research has proven because it's incorrect, okay? Has strongly suggested that it decreased cravings and days of abstinence, right? So that's a high yield point you need to know. That's why I'm saying again, right? As she mentioned, this anti-abuse, it's your aversion therapy. Methadone can reduce cravings and withdrawal symptoms associated with opioids, right? Not alcohol. And so is buprenorphine or Suboxone, right? Suboxone is a very good medication, all right? In practice, we use a lot Suboxone, right? But it's not specifically approved FDA for reducing alcohol craving or relapse prevention, right? Next question. Okay. All right. So how did we get this confused? Which one's the strongest answer?
I felt like the blue one was because you haven't started them on them yet. That's the most important thing to tell them. Is now, have you drank in the last 6 or 8 hours? Because we can't start this.
Okay. Did they say it was a starting dose?
No.
Not specifically.
Not specifically,
But
right?
it seemed like
It
you
says-
would presume.
Right. It says avoid alcohol for at least 12 hours before taking the med. It didn't say while initiating the treatment. So reading into the question, but I don't fault you. I don't fault you because I had to kind of finagle the answer to fit, right? It didn't give me a lot of room. But if you're starting, okay, so even though you don't have a full answer, let's compare to the other option. You have blue. Is that stronger than refrain from using anything that contains alcohol while using this med? Which one is the more complete answer?
The green one.
Refrain.
Yeah,
Refrain.
right? Even though the blue answer could be misconstrued as true if you're initiating the treatment, right? Do you see that, Rebecca? I mean, I get it. What you think?
The question said we were thinking about starting, or the patient
Yeah.
wants to start on
Can
it.
you
So-
repost
Right.
the question again?
Nope, he can't go with it.
So you are right. If the question had said, before starting the med, you must wait at least 12 hours, not 24, before your last drink. That would be a true statement, right? Would be a true statement. And most importantly, you got to wait how long after you stop the treatment?
2 week
to-
watch.
2 weeks, right? You got to wait 12 hours before starting, 2 weeks after, right? These
Right.
are statistics, facts. But if you were to compare the blue and the green, still the green would be a stronger answer. But I see what your point is, and I thought about the same way as I was writing this answer. But
Well, when I read
Thank-
the blue, it says avoid alcohol for at least 12 hours before taking the med. That might just be one day. The next day he can't drink alcohol for 12 hours before taking the med. So that's how I view that. Like,
yeah, this is how I try to convey the message, even though it wasn't clear because it doesn't allow me to do clear answers. But this was the message that I was trying to convey. Like if you have not taken your pill today, can you drink tomorrow because it has been 24 hours? No, you really can't. Really? Because you skip the med today doesn't mean that tomorrow you can have a drink. Okay. But in general, the 12 hours rule is that when you start, let's say I had the drink today, and I'm starting the treatment, I have to wait 12 hours before I really start the treatment, right?
So, Dr. Lopez, can I
Yes.
say something real quick? Because
Sure.
I missed it, but as soon as I missed it, if you looked at answer C and D, they're opposite of each other. So if you use that test taking strategy that, if they're opposites, one of those are going to be right. So, I mean, I knew it as soon as I answered it wrong and couldn't go back.
I did
Yeah.
that. Unfortunately, I compared and picked the blue one.
Okay. I mean, but
Color.
I mean, you guys are in a bind here because one, the answer is not complete, and two is like pick your answer or lose because other people's gonna pick faster and right. But always look for an umbrella answer and don't read into the question. It's very important not to read the question. Don't add anything to the question that's not there or the answer. If it's not said, do not add.
But Dr. Lopez, like you said, it's better to get it wrong here. And
Oh,
so
yeah,
it
any
can be
day.
explained. So for those of us that got it wrong, now is the time, which is, a positive
to me. It's a
Yeah,
positive.
it's a huge
Oh, yeah.
positive because we're learning. We learn more from mistakes. Nobody learns from being A plus, or you have nothing to learn. You're A plus. We all learn from mistakes. That's life, right? So as we do more, engage more, and make small mistakes, we get better as humans and as professionals, right?
Yep. That's why I'm not hiding in the corner, just admitting it.
Right. So here we go. I'm sorry. Sorry about that. Incorrect answer. Oh,
This should have been
incorrect.
D.
Keyed in, right? So we know that opioids, they'll be like, oh, yawning, renal hair,
Yes,
crying
Renoria.
all over, muscle aches, pupils will be dilated or pinpoint?
Dilated.
Dilated. If they are
Dilated.
high, they'll be pinpoint. If they're withdrawal, they'll be dilated. Okay, very important, very important, very important. All right, so sorry about that. My apologies on the incorrect key then, right? But the answer is muscle aches, yawning, irritability, renal hair, or symptoms of opioid withdrawal. So sorry, guys. All right, next question. Okay, so all these answers would have been correct.
That's a really tough question.
What did the question ask again? Because I can't go back to it. All right, doesn't matter. Let's go back here to
Ask which one of these aspects is going to be working on improving their own motivation.
okay.
And we had to pick one.
Actually,
Okay.
I guessed. I got it right, but I actually guessed.
Okay. All right. So we'll go back to frames in a second. Okay. Because I quickly read the question, but I really didn't. So in frames, the F stands for feedback, right? Which is a component of providing objective feedback to the patient about the substance use, its consequence, and the potential risks. The feedback can help the increase of patients' awareness and motivation for change, right? So that was the reason. For a second, I thought the question asked, what are the components of the frame? So if we look at frame, it's, well, let's cut back a little bit, right? So yesterday I said there are a few things that you need to know by the letter, right? One of them is cage. If you kind of know, you're gonna get this wrong. You need to know what cage stands for. You need to know what PICO stands for, and you need to know what frame stands for, and PDSA, at least, right? You need to know what these stand for. So when we look at frame, is a primarily associated model for a brief intervention. How? They use motivation interview. If we think of motivation interview, anytime you're pushing someone to do something, that's not motivational. You have to find within the patient, within the customer, to the willingness to change, often apply for substance abuse or even counseling. So if we look at the frame, then F, feedback, right? Providing personalized feedback about the patient's risks and behavior. The R, responsibility, emphasizing the client's personal responsibility to change. A is for advice, giving clear and direct advice for the behavior change. The M is a funny one, which is a menu. Menu of what? Menu of choices, strategies, and options for change. And E, empathy, right? Demonstrate empathy and understanding. And S is self-efficacy, right? Supporting the change on the client's belief on his or her ability to change. So if you use a frame in a therapeutic context, it most likely refers to the sets of principles. Should you memorize it? Yes. All right. Should you memorize it? Because if you really think, oh, I think I can wing it. Yeah, you can, but you get a 50%, 25% chance of winning, right? Because if I put empathy, I don't know, pick up few words that are close to empathy and it kind of sounds good, you might just feel confused, and especially if this is question 175, right? So you kind of really need to know those letters and acronyms there. Okay?
On this one, it would be easy to have picked empathy because you are building rapport and trust and building them up with your empathy. And so if, the question was, which one's going to work on their motivation, you might get to pick empathy really easy.
Yeah, this is a very hard question, for sure. This one, our brains can be spinned in many different directions and find the reasons for the right answers. Oh, here we go. We talked about cage. This one did the reverse, right? We asked which one is not. Pay attention, they're not. All right. Okay. So I know that have you ever expressed concern about your drinking, right? Have people express concern, but the better answer is, do you ever drink every day? It's not part of the cage, right? Not that the other one is either, but I was trying to convey because of the amount of characters there, right? Do you ever drink every day is not a question in the cage, although that can be taken as an eye-opener, right? But the cage questionnaire focused on assessing the presence of certain behaviors or feelings related to alcohol use rather than the frequency of drinking. That was the point I was trying to make, right? If you want a frequency of drinking, then you would use what scale?
Audit.
Audit, right? Which is the preferred scale, is more comprehensive. Cage, if you score 2+, you would be considered positive, right? All right. So basically here, we got it, this, mostly of us got it correct here, right? Yes, my teenagers frequently gets into trouble at home. So between occasionally and frequently, that was the main distinguish, right? This response is mostly concerned among the options provided there. Indicate the teenager frequently gets into trouble at home when they drink, suggesting a pattern of problematic alcohol use that can have a negative consequence for the family, right? So yes, my teenager gets in trouble at school once after drinking, but it was a minor incident. So although this response suggests a problematic issue, the alcohol, although it described as minor, while it raised some concern, is not without concerns at all. The degree of concerns maybe have be dependent on the specific details not mentioned in the question, right? So we can't necessarily assume. It would still be a concern, but which one is the best answer? The famous nursing dilemmas, right, on tests. I know this haunts me all the time. Which one is the best answer, right? Right, so remember, primary, secondary, tertiary. Okay, so can someone walk me through it? Before I actually do that, my apologies, Joycelyn, I think you had your hand raised and I didn't see it. Do you have a question there?
Yes, I was about to ask if in the event that we have a question that has cage and audit as answer choice, so the best bet will be audit because it's more comprehensive, or
it really depends, right?
Okay.
But if it's in relation to Seabird, we use Cage and Audit, both of them, but the Audit will be most comprehensive. Yes, right.
Okay. All right.
But Cage is very appropriate because you identify and then you can move on to the next level of assessment. How much do you drink? You know, things like that would be more comprehensive. But it's not without it's not that the Cage doesn't have value at all. It has a lot of value, right? Now, can someone, any one of you guys would be willing to walk me through it, the 3 stages of prevention? Primary, secondary, tertiary, if you remember.
Yeah, primary.
Go ahead.
Primary is when like those things have not happened. You're trying to prevent them.
Okay,
And then,
give me an example. Give me an example.
just like educating people on a particular disease prevention, like depression, like, you know. Then secondary will be like screening, like all those suicide lines, all those lines will be like secondary. And then tertiary is like that stuff already happened, then you're trying to rehabilitate people from it, like, you know, to prevent maybe further destruction or further whatever. So that would be like the tertiary.
Okay, so calling the crisis hotline, is that secondary, primary, or tertiary?
Secondary.
Okay. Blood pressure and screening, is that primary, secondary, or tertiary?
That is screening, so but
Screening, secondary.
Yeah, good job, Jennifer. I think it was Jennifer there, right? Because I said screening. So hopefully
Screening, yeah,
because it's screening. So P for primary, P for prevention. C, I mean, I'm sorry, I said C. S secondary, screening. And tertiary, it's rehabilitation. So when you're providing meds, is that more towards, if it's one time, you know, I mean, you can get in details, but like when you are doing it for a while, that's tertiary. Okay. So like a rehab, for whatever reason, you know. So if you are doing class for smoke cessation, not cessation, prevention, right? That would be primary. If you do smoke cessation, that means they're already smoking. Right? Then there would be
secondary.
That's tertiary, because sensation. You just maintaining
right?
it.
If they're already smoking, now would be a tertiary, right? Because you're no longer screening, they're already smoking, you're trying to quit, right? So secondary is like the screening for blood pressure, labs, and things like that, or diagnosing the patient, right? But just pay attention on those key words. If it's P, prevention, S for screening, and T for tertiary for rehabilitation, right?
Where does vaccination fall?
So is it, good question. So is it vaccination or prevention? Is it a screening or tertiary?
Prevention. Primary.
Yeah.
Prevention.
So, yeah, when you
Primary.
get those questions, don't get sucked into answering the question. Ask yourself, is this prevention? Is it a screening, or is it doing the treatment already, right? So primary will be more of a prevention.
Prevention.
Yeah. So good job. So sometimes we get in a habit of allowing the questions to trick us. So one way that I use to not get tricked is asking myself, what is the question asking me? What is the core of the question? Because the questions will be long. And then you just like summarizing in 2 words, what is the question asking me? Almost will be an answer that is correct, but is not answering the question. Be on a watch out for that. Because if we talked about medication, it may say that, yeah, this medication is great because it's used to treat psychiatric or psychotic condition. But if that's not related to the question, if it's not answering the question, it cannot be the right answer, right? So it could be the right answer, is just not answering the question. It is a correct answer, but not for the specific question.
Cryberry. Oops.
Okay, glad to see this. Remember, another test taking strategy is a weird answer. Never pick a weird answer when you don't know what that is, because there is no such a thing as protective factorial prevention. That's not even a word. I mean, it's like something made up out of thin air, right? So we know that when students don't quite know the answers, they tend to pick something that they never heard of, because it's a defense mechanism. If I never heard of, that must be the answer, right? So when in doubt, don't pick something that you never heard of. Okay, I know you feel the urge to pick that, but don't do it. Dream.
Yeah, that was my strategy in school.
Twice, I got victimized. I made
Good job there. All right, so let's take a look on the rationale and keep on going. Take a read on the rationale, please.
You want someone to read it?
No, just read it on your own, so you kind of like refresh your. Thank you, Rebecca. Your memories there. All right. Next question. Okay, so in motivational therapy, if you ever found yourself pushing anybody around, then it's not likely to be motivational therapy, even though you're pushing them towards the right path and something that you believe is right for the patient. But let me tell you why quitting alcohol is essential for your health is not motivational, right? Motivational is, tell me how the alcohol has affected your life. Let the patient self-discover, right? Well, it sounds horrible that you have lost your job due to drinking on the job. How did they make you feel? Instead of saying, this is unacceptable that you lost your job due to drinking alcohol on the job, right? You shouldn't do that. Even though it is the right, it's not wrong, it's just not motivation. You cannot impose your thoughts and ideas on somebody. You have to let them discover and find the way out. You are there to guide, coach, teach, and mentor them, right? Because they really know the answer. You just try to enlighten the situation, right? How do you feel about alcohol use? What are your goals regarding it? That's an excellent way of putting it, because okay, my goals is to stop drinking, or my goals is to drink less. You know, and yeah, I think alcohol has gotten in the way of my marriage, and I feel very distressed, and I'm willing to stop drinking, or not, right? Ooh, this is a very, very hard one, right? Extremely hard one. Because I like it, empathy there too, right? But this is a role with resistance. Like, hey, what is, like kind of confronting or challenging the patient, resistance to group therapy, but in an empathetic, not confronting, I would say more of let's troubleshoot what are your concerns, right? Better understand what are your concerns, that so that I may be able to provide advice, not kind of confronting, you must do it, right? This approach aligns with the MI principle of working with the patient resistance in a collaborative manner, right? But I really like empathy there too. And I express empathy. While express empathy is fundamental in the MI, it is not a primary principle evidence in the interaction, right? So that's like, you gotta have empathy, but when it comes to MI, it's more so of rolling with the resistance in this scenario, right? So, but it's a hard question because you could almost make the case for all four of them, right? Very hard question. All right. Can someone give me some example of what a pre-contemplation is?
Pre-contemplation is when the patient is not ready to change.
Perfect.
Contemplation is when the patient knows that they have a problem and express some desire to change but haven't started. Preparation is that they want to change and they're going to be starting in the next couple of days, weeks or so. And action, they've already initiated the change.
Okay, how about maintenance?
Maintenance,
Between maintenance and action, how is the difference there?
So,
how long? The time frame?
Is it 6 months or is
6
it
months.
6
Yes.
months or more.
Yeah, so very good, right? Excellent. So you guys really need to understand this because this is a beautiful concept, not only for the test, but for practice, right? You can't offer something to somebody that they don't need it or they think they don't need it, right? It doesn't matter what it is, can be gold, diamond, a course. If they don't think they need it, they're not going to get it because they don't need it. They don't need that. So that is pre-contemplation. I don't have a problem. Why should I attend alcohol use disorder class? Oh, no, just for awareness. Well, go make awareness for somebody else. I don't have a problem, right? So if they don't perceive that they have a problem, then don't give no advice. Contemplation, it's like, I think I have a problem. I want to stop drinking, but I don't know. Maybe I should, maybe I shouldn't, right? So the individual are aware that the problem exists and are serious contemplating, considering, overcoming, but have not made a commitment to take action. Okay, I know that alcohol is a problem and it has affected my marriage, and I really want to stop. I want to take action within the next few days, week, and start attending Alcohol Anonymous meetings, right? So I'm doing the preparation. Now I have arrived to the meetings and I'm doing a weekly and has been less than 6 months. So now I am in action. After action is what I want to warn you, which is the maintenance. After 6 months, I've been attending my meetings every day, and now I feel sober and empowered, and nothing's going to get me, right? So your job, not only for alcohol use disorder, but for any medications, really, your job, if you want to use that kind of steps for medication, is not necessarily what we use for, but everyone goes through that, right? Oh, no, I don't have depression, or I do, blah, blah, blah. So what I'm saying is that your job is the maintenance phase, especially with medications, to tell the patients, hey, you will feel better, things will get better, and that's where you are now. But I want to warn you to keep on the medication for at least 9 months. In this case, is warning the patient that although they feel competent and they feel empowered and they feel that you're in a good place, be careful not to hanging out at the bars, old friends, or getting to emotional states that could cause a relapse, right? Dreamy, you're on the road there. Oh my God, how many 8 correct answers in a row? Congrats. I see you doing a lot of questions. Good job. Okay, great. So the point here that I was trying to convey is that if they don't assume responsibility, whether they're inpatient or intensive outpatient program, and say, I own it, I did it, they are now ready to change. They're now ready for discharge, right? I had the borderline patient that always go, oh, no, it's because my girlfriend, she called me and she started fighting and it makes me feel that way. So he's not showing readiness for change. that they are ready to be discharged, right? So how do you know when the patient is ready to be discharged? When they take responsibilities for their own actions, right? In this case, the best example is I still struggle with cravings, but I know it's my responsibility to manage them. Not saying that we would not help them, but ultimately, who is responsible for their own bodies and attitudes is the patient, right? Okay, it's kind of hard too, right? Hard question. Can you describe the steps you have taken to reduce cocaine use? So if the patient's in preparation, you asking this question, right? It would align with no, I haven't, or I have not, right? Um, kind of, it's a hard question though. I can tell you this is a very hard question because other answers that also aligns.
Yeah, the
with
answer that was correct says he already has a plan, and that means he's not in preparation. That means he doesn't know he has a problem. So the A was, do you think cocaine has become a problem? I think it
Right.
should be.
Yeah, I actually didn't. You
No,
gotta
preparation means that the patient is actively ready to change.
preparation. The patient's actively ready to change. Correct.
And they are working towards the change. Would it be like they are going to like classes, doing something actively towards that change?
Well, they'll be if they are going, they're already in action. They're doing prep, calling, scheduling, committing to going. If they are already at that, that's action, right? So the question is most appropriate for assessing the preparation stage because it encourages the patient to discuss the concrete steps they have taken or are planning to take to reduce their cocaine use. It aligns with the principle of awareness to make changes and actively plan for change, right? Why do you think cocaine has become a problem for you? This question explores the patient understanding of the problem, which is relevant to someone in the contemplation phase, right? Because they say, hey, I'm contemplating. In the preparation stage, the patient is more focused on planning and taking action. Are you confident that you can quit cocaine on your own without any support? So this question assumes that the patient is considering quitting on their own without any support, which may not be the case in the preparation stage. The preparation stage often involves seeking and planning for support, right? Have you considered attending a cocaine addiction treatment plan? Again, this question focuses on a specific treatment option. It may be more relevant in the contemplation or action stage, right? So those questions are hard, right? They are hard because one, it really depends on how you read the question and how much you read into the question, right?
Yeah, our notes say.
Sorry, we'll go back to that one in a second. All right, we got 10 seconds left. Perfect. All right, so Marshall Lineham for DBT, right? Very important. What is the goal of DBT? To decrease crisis. The goal of DBT is to decrease crisis, right? All right, so let's see who took third place. Tim Faith. And second place is Chris. All right, you did it, dreaming, yeah. Jennifer and Stefan, fourth and fifth place. You guys rock. Good job, everyone. As I mentioned, right, it's a competition, and it gets tighter, and more difficult as other people join, and the larger amount of folks join our course. It gets a little bit more difficult, right? But if you are constantly scoring the top 10, right, this is a good indication that you're very close to your final destination. And if you are not, don't despair. Every time you show up, every time you learn, every time you make a mistake, you learn even more. Okay, so let me take a shot here, screenshot of this, and we can answer some questions from yesterday event. 1 second.
Dr. Lopez.
Yes.
I bought the flashcard, but I don't know how to get into it.
Okay. Did I send it to you yet? Did I send it to you?
No, I haven't received anything, but I bought it last night.
Okay. Yeah, I just couldn't get to my email, so please allow me, like, as soon as I finish here, I gotta look at that, and then I'll send you an email, and I'll send you how to access it. Okay.
Okay. Do I need to send you an email, or you
No.
send it? Okay.
You should not need to send me an email. I should see your account and then be able to look at it. It's just it's a manual process, and then that takes a little while for me to get to it. But I'm getting to it very soon. Okay. Thanks for reminding me there.
Thank you.
Absolutely. So from yesterday's class, is there any questions or concerns? Let's go ahead and do this. Let's take it is 8:00 p.m. Let's take a 10 minutes break. Let's be back at 8:10, and we'll kind of go over yesterday's very fast to see if there is any questions remaining, or if you have any questions with the course, or if you need any other type of assistance. So let's be back at 8:10 p.m. and I'll see you guys very soon. Okay.
Yeah, Dr. Lopez, please add me to the WhatsApp group. I texted you yesterday on the WhatsApp, please.
Yes. Yeah, like I said, I haven't been able to get my phone or my email yesterday, but I will. As soon as I finish this class, it will be my catch-up day. Okay?
Okay.
I'll be able to do that as soon as I finish here. See you guys at the 8:10 in 10 minutes, and we'll go over a few concepts from yesterday and any other questions that you may have. See you soon.